So hello everyone, welcome to this next module. So in this module, we are going to learn regarding the basics of spirometry. So the discussion will be in an entrance oriented manner, and I feel this is a very important module, a very simple one. I feel that you might get a question for your exam where you will be given a clinical scenario and the values, the spirometric values will be given, and you will be asked to interpret them and come to a conclusion or a diagnosis. Now, don't get frightened seeing all these values. If you understand the basic concepts and you understand the basic patterns, okay, of a obstructive lung disease and a restrictive lung disease, things are a lot easy. We will discuss them in detail. Okay, so let's start. So let me begin by telling you that in this module, what I will be doing is that I will be starting off with the basic lung volumes and capacities. Just a recap, because you have already learned this in your physiology lessons, but we'll just have a quick recap of the basic lung volumes and lung capacities. And after that, we will move on to the spirometry. So how this procedure is going to get us various values, and with the values, what about the volume time plots, and how do you interpret the volume time plots, and then we will slowly move on to the flow volume loops as well. How do you interpret them? And I'll also make a mention of your DLCO, that is your diffusion capacity of carbon monoxide. Okay, so that is the agenda for this module. So let's begin. First of all, a quick recap of the lung volumes and lung capacities. So lung volumes, as you know, there are 4 lung volumes which are important. Okay, so what are the lung volumes which are important? The first one will be your tidal volume. Okay, tidal volume, which is abbreviated as TV. Second one is inspiratory reserve volume. Inspiratory reserve volume, abbreviated as IRV. Third one is expiratory reserve volume, which is abbreviated as ERV. And the final one is residual volume, which is abbreviated as RV. Okay, let's see what are these. First of all, tidal volume. Okay, very simple. Just have a look at the graph here where you have the time versus the volume. Okay, the volume actually showing the amount. First of all, tidal volume means, what is tidal volume? It is nothing but the amount of air that goes in and out of the lungs in a normal respiration. Okay, amount of air going in and out of the lungs. You see here, this is the tidal volume. You have a normal respiration. It's not a forceful inspiration or a forceful expiration. Just a normal respiration is going on. What is the amount of air going in and out of the lungs? That is tidal volume. Okay, clear. That is TV or tidal volume. Next is inspiratory reserve volume. Okay, now inspiratory reserve volume means it is the excess amount of air. Remember, excess amount of air, which means over and above the tidal volume. So what is the excess amount of air that can be inspired in, okay, that can be taken into the lungs after forceful inspiration? Okay, you see here, this is your inspiratory reserve volume, okay, from here to here, which means beyond the tidal volume, what amount of air can be breathed in with a forceful inspiration. That is what you call a inspiratory reserve volume, IRV. Clear? Next is expiratory reserve volume. Let's try to see what an expiratory reserve volume is. Expiratory reserve volume is again the excess amount of air, which means above the tidal volume, which can be expired, okay, out of the lungs with a forceful expiration. You see here, this particular region, okay, or you can see this is the particular amount of air that can be forcefully expired, that is beyond the tidal volume. Okay, so it is a forceful expiration and not a normal respiration. Okay, so that is called a expiratory reserve volume. So that term is also clear. The final term is called a residual volume. It's nothing. It is just the amount of air that remains in the lungs. Okay, the residual volume means it's a residual air that remains in the lungs even after a forceful expiration. That is, a maximum forceful expiration is going on, and after that, what is the amount of air that remains in the lungs? As you can see here, this is the amount, because here the patient has expired forcefully, and even after that you have this amount of air remaining in the lungs, that is called a residual volume. Okay, important. TV, IRV, ERV and RV are the important lung volumes. Okay, so that is very, very clear. All right, because you have got to know this basic facts, only then you will be able to interpret the various values. Okay, all right. Now coming to the capacities. Okay, we have learned the lung volumes. Now coming to the capacities. Capacities also you have got to learn 4 capacities. So number 1 is the inspiratory capacity. Inspiratory capacity. And number 2 is the functional residual capacity. Functional residual capacity. Number 3 is the vital capacity. And number 4 is the total lung capacity. Simple. Okay, 4 capacities. So inspiratory capacities. Okay, inspiratory capacities. Often these capacities are a combination of the various volumes. See, inspiratory capacity means it is the maximum amount of air. See, the term is capacity of the lung. Okay, inspiratory capacity of the lung. So what is the maximum amount of air that, okay, the maximum amount of air that can be breathed in, okay, after a forceful inspiration. So you are going for a forceful inspiration, and what is the maximum amount of air that can be breathed in, which means this will always be a combination. You see here, starting from here, beyond, you see the tidal volume is there and also the IRV is there. So the tidal volume plus inspiratory reserve volume will be your inspiratory capacity. Okay, inspiratory capacity. Very clear? All right, so that is clear. Second term we are going to see is your functional residual capacity. Remember, it is something that is residual capacity. Okay, residual capacity, which means it is the amount of air that remains in the lungs after a normal respiration or an expiration. Okay, so you are having a normal expiration, and after that, what is the amount of air that remains in the lung? Remember, normal expiration, which means it will be the sum total of your expiratory reserve volume and the residual volume. That will be your functional residual capacity. Okay, clear? As you can see here, this is the FRC. All right, simple. Next term, be very, very attentive. Okay, this is a very important one, is your vital capacity, or VC as you can call it. So vital capacity means it is the amount of air. Okay, it is the amount of air that can be forcefully expired after a maximal inspiration. So somebody has gone for a maximal inspiration, okay, which means he has inspired the tidal volume plus the inspiratory reserve volume. So that is a maximal inspiration. Now after this maximal inspiration, what is the maximum amount of air that can be expired? Okay, so starting from here, what is the maximum amount of air that can be expired means it will be the sum total of what all? You have your inspiratory reserve volume, your tidal volume plus your expiratory reserve volume. Okay, because a person can expire up to this much. Okay, very, very important. So that is what you call your vital capacity. Vital capacity. and the total lung capacity is nothing but the sum total of the inspiratory capacity as well as your functional residual capacity, that is your total lung capacity. Okay, so the volumes and capacities, very simple, just understand these. Okay, all right, so it is less likely that they might ask a direct factual question from this, but you've got to understand this. Okay, only then you will be able to make sense. Often what happens is, a student might try to solve the questions without understanding the very basics. So that is when you tend to make silly mistakes for such questions. All right, so just to have a quick look at the values of the various volumes and capacities which we have learned. First of all, let me tell you, these are approximate values, because actually in males and females you have differences in these values, and the values given here are an average. Okay, so let's have a look at the average, because that is often used for solving questions. Okay, and see the volumes. The tidal volume is around 500 ml, IRV 3 liters, expiratory volume, that is expiratory reserve volume 1.1 liters, some say it is 1 liter, and residual volume 1.2 liters. So these are the important volumes. Inspiratory capacity 3500 ml, that is 3.5 liters. 2.3 liters is your functional residual capacity. 4.6 liters is your vital capacity, keep that in mind. And total lung capacity 5.8 liters, you can almost take it up to 6 liters. Okay, for convenience you can take it as 6 liters. These are the important values that you should know of. Very clear. Okay, because you should know this, because in the exam they will give this values as a part of the questions. So you are supposed to know what is normal. Okay, as is said, only if you know the normal you will be able to identify the abnormal. Okay, all right. So now let's move to the basic spirometry. So spirometry, is a simple technique. So which is most of the hospitals have a spirometer lab. So at present, we are using the handheld spirometer, automated spirometer devices. The previous generation devices used to be more cumbersome, but now you have such a device which you can see on the screen, which is a handheld device. And in this particular region, you can also have a mouthpiece, okay, that is going to be connected. And that mouthpiece, if used by one person, it is discarded, and for the another person you are using a different mouthpiece. So this is the device that you commonly use, okay, the spirometer device. So let's try to see more about this technique. So here, when you are doing this spirometry after an inspiration, he is the person is asked to forcefully expire into these mouthpiece. Okay, like you take a deep inspiration and then he has to forcefully expire through these mouthpiece. Okay, and then you will get the values. Okay, and these spirometry handheld device is often connected to a computer as well, so that you can comfortably analyze the values and the graphs as well. Okay, so that is how you do it. So suppose we are having a spirometer lab. Now I'll just ask your imagination to go to a spirometer lab where you have a patient, maybe even a normal individual, who is forcefully expiring to this the device, the handheld device. And when he is forcefully expiring, okay, you tell me what is the maximum amount of air that he can forcefully expire after a maximal inspiration. Because in your spirometry, when you are doing, you are asking the patient to do a maximal inspiration and then do a forceful expiration. So what is that amount? Vital capacity, correct? Vital capacity. So you can say it is a forced vital capacity, because you are forcing out the air into the mouthpiece, okay, of the spirometer. So that is called a forced vital capacity. Now I am going to show you, okay, that is when you do a spirometry, you get a plot of your volume time. This is called a volume time plot. Okay, volume time plot. Please have a look at this, because you might get such a similar plot for your exams. So when you are forcefully expiring, the maximum amount of air that you can forcefully expire will be your what? Forced vital capacity. Okay, forced vital capacity. So that is your FVC, forced vital capacity. Now an interesting feature of this forced vital capacity is that when you forcefully expire, almost 80 to 85%, okay, almost 80 to 85 percentage of the air that is expired, okay, will be happening in this first second, okay, in the first second. So as you can see here, this is the time in seconds. So you see here, by the first second itself, you have almost reached, okay, almost reached, this is the maximal height, okay, which I am marking in red is the maximal height, and the violet is almost 80 to 85 percentage. So that value that you are forcefully expiring in the first second is what you call FEV1. Okay. So 85 percentage is expired in the first second and you call it what? FEV1. Okay. Which is always about more than 80 percentage. Okay. Which is more than 80 percentage above the vital capacity. So more than 80 percentage of the vital capacity is expired in the first second. Clear? So this is the normal volume time plot. Okay. You have got to have a good understanding of this, because only then you will be able to identify the abnormalities. So after the first second, you can see that it actually goes to such a stage, almost slow rise, okay, almost plateauing. All right, so this is the normal volume time plot. Now this normal volume time plot you have got to keep in mind, because in various disorders, because in pulmonology you can categorize the various disorders into an obstructive lung disease, a restrictive lung disease, or maybe a pulmonary vascular disease. Okay, so you can have obstructive, restrictive disease as well as a disorder involving the pulmonary vasculature. So how does this plot, the volume time plot, help you differentiate between these disorders? That is your obstructive lung diseases and restrictive. Okay, so that is what we are going to learn. Okay, this volume time plot is going to help us to differentiate between these two. Okay, the obstructive and restrictive. Regarding vascular disorders, we'll come to later. So let's see how it is. So obstructive, classical examples are your COPD and your bronchial asthma. Okay, bronchial asthma, where predominantly the problem is the expiratory airflow limitation. Okay, so in obstructive lung diseases, the predominant problem is the expiratory airflow limitation. Okay, so that happens in obstructive lung diseases. Whereas restrictive lung diseases is predominantly characterized by a inspiratory problem. Okay, so the classical example of a restrictive lung disease is, say, your interstitial lung diseases, ILD. So where you have a small lung, so definitely the amount of air that can be inspired. Small lung means there is some sort of fibrosis that is happening into your interstitium. So the amount of air that actually comes in is actually less. Okay, so that is what you have a restrictive lung disease, predominantly a inspiratory problem. Okay, inspiratory problem, predominantly inspiratory problem. Okay, all right, so just like try to see the abnormalities. First of all, we are going for the same volume time plot. Okay, this is the same volume time plot. Okay, are you able to see the volume? Are you able to see the time? So first of all, in this first figure, I am going to compare normal versus obstructive, and in the next plot that I am going to show you, not in this one, I am going to compare a normal versus restrictive. So first, see the normal. What you can appreciate is the one in orange that you can see is the normal volume time plot. Now what happens in obstructive lung diseases is, so obstructive, I told you, it is a predominant expiratory airflow limitation. And in spirometry, you are asking the patient to expire forcefully into the mouthpiece. So the plot will not have the same shape as a normal individual, and in case of obstructive lung disease, you can see the blue line, how it is going. You can very clearly see. It is not the shape. The shape is very different. You can see it is a sloping one. Okay, correct. It is. You can see the slope. Correct. So the shape is very much different. And if you see the FEV1 there, I'll just show you with a different ink. Maybe the red one to make it clear. Okay. So you see the FEV1. Okay. And just compare with the FEV1 of the first curve. Okay, that is your normal. You can see the FEV1 is actually very less. Okay. The FVC is only slightly less here. Okay. Because this is where your FVC is. For both the curves, you can see there is not much of a big difference. But where is the big difference? It is in the FEV1. Okay. FEV1. Now remember, when you try to interpret the spirometric values, one of the most important parameters that you would look for is the FEV1 to FVC ratio. Now this is very, very important. Now in your exams, you might be either given this ratio straight away or you might have to calculate. But whatever it is, this ratio is very, very important in the differentiation between a obstructive lung disease and a restrictive lung disease. Okay, all right. So now you tell me, when you take into consideration obstructive lung disease, what will be this ratio? FEV1 to FVC. Remember, both FEV1 as well as FVC will be reduced. But what is more strikingly reduced? It is the FEV1, as is very clear. Why is it not more strikingly reduced? You can see the graph shape itself is very different, and you can see at the end of first second the FEV1 is very less. So this ratio, the FEV1 to FVC ratio, is very much decreased. FEV1 to FVC ratio is decreased in case of what? Obstructive lung diseases. Okay, so in your obstructive lung disease, you will have a lower value of your FEV1 to FVC ratio. Okay, very clear. Now next is, so this part is very clear. Okay, obstructive lung disease, what happens to the FEV1 to FVC ratio? It will be reduced. Okay, all right. Now let's come to restrictive lung disease. So this is the next volume time plot, and in this volume time plot, we are going to compare normalcy versus restrictive lung disease. So normalcy is the orange curve that you are seeing here, which is very clear for you. Okay, and when you take into account the yellow, that is your restrictive, you see here the amount of air, the total forced vital capacity, you can see is very less compared to normal. Now why is it so? Because see, it is predominantly a problem with inspiration, but only if you inspire adequate amount of air, you can expire also. So here the forced vital capacity is reduced. Why? Because you have lesser amount of air coming in also, so lesser amount of air going out also. So here you see the FVC is reduced, your FEV1 is also reduced. Okay, but you see the shape of the overall plot. Does it look very much different? Okay, you remember the plot of obstructive lung disease, which I'll again take you to. Are you able to see the plot of obstructive lung disease? Now you compare this plot to the plot of a restrictive lung disease, which is almost a miniature form or a smaller form of what? Your normalcy. Okay, it looks almost very same. So you see here the shape is almost same. Okay, but only thing is that this is very small. So the point I want to tell you is about your FEV1 to FVC ratio. FEV1 to FVC ratio. See what happens in your interstitial lung diseases is, you will have a FEV1 reduction, you will also have a FVC reduction. But when you take into the consideration the ratio, okay, FEV1 to FVC, that will be normal or increased. Okay, It is not going to be a lower value because the more proportionate reduction will be in your FVC. Okay, so that when you take the ratio, it will be a higher value. So you might find that the FEV1 to FVC ratio is actually higher in case of your restrictive lung diseases. So far in this basics of spirometry, we have seen the volume time plots of an obstructive lung disease versus a restrictive lung disease, and we have seen what happens to the FEV1 to FVC ratio as well. Okay, it is reduced. Okay, so in FEV1 to FVC ratio it is reduced. So how much reduction is significant means you have different guidelines. As per the American Thoracic Society, they say that they have a set of guidelines based on the age and sex. So below the lower limit of normal is taken to be the criteria as per the American Thoracic Society. But as per the GOLD, okay, which we have discussed in COPD, that is the Global Initiative for Obstructive Lung Diseases, the value taken is 0.7. So in case of your lung diseases, obstructive lung diseases, FEV1 to FVC ratio is less than 0.7, whereas in case of the restrictive lung diseases, the value is normal or increased. Okay, very clear. So far we have made good sense of the volume time plots. Okay, volume time plots. Okay, now I will just make a mention of before that, just one thing. See, when you do a spirometry, okay, one thing that you should be careful of is that you see here, this is your residual volume. Okay, residual volume cannot be estimated by your routine spirometry. Okay, which means not just the residual volume, but the capacities that involve the residual volume, like a functional residual capacity or a total lung capacity in which residual volume is also a part, they cannot be estimated by the routine spirometry. For that, you have got to go for techniques like a nitrogen washout method or a body plethysmography. Okay, so these are techniques, just know the name. Okay, so routine spirometry, nor can you assess the residual volume, nor can you assess the capacities involving the residual volume. Okay, coming back. So far again, let's try to see where we are. We have seen the volume time plots and the differences between the obstructive lung disease and restrictive lung disease. And we have seen regarding FEV1 to FVC ratio as well. Okay, now just a mention of DLCO. Okay, what is DLCO? So DLCO stands for diffusion capacity for carbon monoxide. So it stands for diffusion capacity for carbon monoxide. So this is a separate technique, but I'll tell you this is very important because after discussing DLCO, I would be showing you a flow chart on making a distinction between the various lung disorders. For that, DLCO is very important. So DLCO is nothing but diffusion capacity of carbon monoxide, by which I mean, you have the alveoli here. I just have a diagrammatic representation. Okay, you have the alveoli here and you have the capillaries here. Okay, the arterial end, the capillary end, and the venous end. So here is where you have the alveolo-capillary membrane. Okay, so that is where the diffusion of gases is taking place. That is oxygen, carbon dioxide. Now, diffusion capacity of carbon monoxide is a test, okay, that relies on two factors. That relies predominantly on two factors. One factor is going to be the integrity of your alveolo-capillary membrane. The integrity of your alveolo-capillary membrane. Okay. And second is going to be your gas exchange surface area. Okay, when I say gas exchange surface area, it means the surface area available for gas exchange at the alveolar level. Okay, Now this test DLCO depends on these two. Now what is done in this test is that you're trying to measure, okay, the diffusing capacity of carbon monoxide. Now why carbon monoxide is chosen for this test as a test gas is because in the speciality of carbon monoxide is that this carbon monoxide has a high affinity for your hemoglobin. Okay, it has a high affinity for hemoglobin. Okay, so because of which this is an ideal gas to test the diffusion across the alveolo-capillary membrane. Okay, so you are trying to test the diffusion across the alveolo-capillary membrane, and when you have disorders where you have affection of your alveolo-capillary membrane, like say your interstitial lung disease, okay, ILD, where it is affected, the diffusion across the alveolo-capillary membrane is affected. So in such a disorder, as well as in disorders like anemia, where you have low hemoglobin content, okay, and also in disorders where again this gas exchange surface area is affected, like your emphysema, in these conditions, what will happen is that there will be a decrease in the diffusing capacity of carbon monoxide. Why there is a decrease is because either the alveolo-capillary membrane is affected or your gas exchange surface area is affected, because in your emphysema the gas exchange surface is not adequate because there has been destruction of your at the alveolar end, so because of which you are not having enough surface area for gas exchange. So in such conditions you will have a decrease in the DLCO. So just to revise, emphysema, interstitial lung diseases, and also your pulmonary vascular disorders, okay, like your pulmonary arterial hypertension and pulmonary embolism, where again the vascular end of the alveolo-capillary membrane is affected, and your left-sided heart diseases like heart failure and also anemia. These are conditions where the DLCO will be reduced. Now this is very important to keep in mind, the list of conditions where DLCO is reduced. Okay, so you keep in mind this list. Certain conditions are there where you can have an increased diffusing capacity for carbon monoxide. So one would be a polycythemia, okay, where you have increased availability of your hemoglobin, so which means naturally more carbon monoxide would diffuse, and also pulmonary hemorrhage. So pulmonary hemorrhage and polycythemia are two conditions where you get a increased DLCO, okay, diffusion capacity of carbon monoxide. So you have got to keep in mind this entity. So DLCO actually depends on lot of factors. Though we have discussed the important disorders, it depends on the alveoli, okay, the gas composition, the basement membrane, the capillary, the plasma components, and the cells at the pulmonary arterial end. It depends on a lot of factors. But for your exam, remember DLCO is predominantly dependent on the alveolo-capillary membrane integrity and the gas exchange surface area available. Okay, so when there are disorders affecting this, you will have a impairment in your DLCO. Okay, very clear. So DLCO is also very clear for you. So next, we are trying to go to a flow chart to distinguish the restrictive and obstructive lung diseases. But before that, just a quick recap of the various obstructive and restrictive lung diseases. So I have discussed this in the corresponding sections in the pulmonology module where the individual disorders have been discussed, but just putting everything together, remember obstructive lung disease, COPD and asthma will be the prototypes, but you have other disorders like alpha-1 antitrypsin, bronchiectasis, bronchiolitis obliterans. These are just other examples. So restrictive means, it can be a chest wall problem, okay, you can have a kyphosis, and obesity can be a problem, and neuromuscular junction problems you can have in diseases like myasthenia gravis, okay. Then you can have lung problems like your interstitial lung diseases, okay. So all these are causes of restrictive lung diseases. Detailed discussion has been done under separate topic discussion in this respiratory module. So what are we going to learn next? Up next, we are going to learn a simple flow chart. Remember I told you, when a question comes for the exam, you have got to have a basic idea regarding certain patterns that you are going to expect, okay, in the obstructive and restrictive lung diseases. So the spirometry values are going to help you, plus your knowledge of DLCO will help you. So that is why we are going to that flow chart up next. And let's see the simple flow chart. Okay, so this simple flow chart taken from Fishman Pulmonology. So this is there in all textbook. This is the standard one of differentiating obstructive, restrictive and vascular lung disorders. So first parameter you have got to do when you are wanting to differentiate this disorder is, most important one, you go for the FEV1 to FVC ratio. Okay, it is written as VC here, it is nothing but the forced vital capacity. So you go for this ratio. So remember, as per the ATS, American Thoracic Society, they take the lower limit of normal. There are a set of standard values. So if it is above lower limit of normal, or you can say above, remember for gold they have kept the value as 0.7. So you first check whether the value is above normal, okay, or it is again below the lower limit of normal. That is what you are looking. Now suppose you have gone for this ratio and you find that the ratio, that is the FEV1 to FVC, is higher, okay, higher value. So in such a scenario, once you find the value is high, then what you do is that you go for the measurement of the vital capacity, that is your forced vital capacity. Initially you measure the FEV1 to FVC ratio. So second you look, once this ratio is high, you look for the FVC, forced vital capacity. Now if this FVC, okay, suppose you can have two scenarios. One is in which this forced vital capacity is above the lower limit of normal. Okay, it is above the lower limit of normal, and the other is where it is not above the lower limit of normal. Now suppose you have the higher ratio of FEV1 to FVC, as well as the forced vital capacity is also the above the normal limit of normal, lower limit of normal. Then what you do is that you measure the DLCO, diffusion capacity for carbon monoxide. Now imagine a scenario where the DLCO is also normal. The DLCO is also normal. You are probably dealing with a very normal individual. Remember, his ratio was high, FEV1 to FVC, no abnormality. You measured the FVC, that also was normal. Okay. Even then, you may have abnormality, especially when your pulmonary vasculature is affected. So you know that in conditions like pulmonary embolism, your DLCO will be affected. So that is why you went for the DLCO. And if your DLCO is normal, you can say that this is probably a normal individual. But if the DLCO is not normal, suppose this DLCO is abnormal, then you are probably dealing with a pulmonary vascular disorder, like a pulmonary embolism. Okay, so that part is very clear. Okay, all right. So now you have seen the forced vital capacity. Okay, if the forced vital capacity is above the lower limit of normal. Now what if the FEV1 to FVC ratio was high and you have measured the forced vital capacity and you find that the forced vital capacity is on the lower side. Okay, so we have seen the forced vital capacity is on the lower side. Now what are you going to do in such a scenario? In such a scenario, you have got to measure your TLC, that is your total lung capacity. Total lung capacity. Now you tell me what will happen to the total lung capacity in case of a restrictive lung disease, because you remember restrictive lung disease, the total lung capacity will be smaller, okay, because it can hold a smaller amount of air only. So small, it will be a lower one. That is, so if the total lung capacity is low, then you are probably dealing with a restrictive lung disease. You are probably dealing with a restrictive lung disease. Okay. Now, in such a scenario, when you have a probable restrictive lung disease, This could either be a chest wall problem or a neuromuscular problem, or it can be an interstitial lung disease. How do you differentiate? You go for the DLCO. If your DLCO is abnormal, which means there is some problem with your alveolo-capillary interstitium. That is, when you talk about alveolo-capillary membrane, it includes the interstitium as well. So in ILD, interstitial lung disease as well as pneumonitis, you will find that the DLCO is low. DLCO is low here, whereas in chest wall, CW is chest wall and neuromuscular abnormalities, DLCO is normal. Okay, very clear. Clear? Now, what if the total lung capacity that you have done is either normal, okay, or above the lower limit of normal? In such a scenario, you should consider the possibility of an early obstructive lung disease. Remember, early obstructive lung disease. Now, this is in spite of the fact that in this part of the flowchart that we have learned, remember the FEV1 to FVC was either normal or increased. So that can actually happen in an early part of an obstructive lung disease. So when you evaluate and find that the total lung capacity is either normal or high, remember this is not going to be a restrictive lung disease. This is going to be a early or an evolving obstructive lung disease. All right. Okay. So just to summarize what we have learned so far. Okay. First of all, remember we are going for the FEV1 to FVC ratio. Now, what if the FEV1 to FVC ratio is normal? You go for the FVC, and if the FBC is also normal, okay, then what will you do? You will go for the DLCO, and DLCO is also normal, means it is a normal individual. If DLCO is reduced, this could be a pulmonary vascular abnormality, where the other values will be normal, your FEV1 to FVC and FVC will be normal, but DLCO alone would be affected. Okay. Now, if you checked initially and you find that the forced vital capacity is above the lower limit of normal, in such a scenario, go for the total lung capacity. If the total lung capacity is reduced, okay, you are thinking of a restrictive lung disease, and to differentiate between whether it is a ILD or a pneumonitis or whether it is some chest wall abnormalities, then you can go for DLCO, because in chest wall abnormalities, you are never going to have any abnormality in your DLCO. It will be abnormal in ILD as well as pneumonitis. That is very important. And remember, if the total lung capacity is normal or above the lower limit of normal, you can think of an early obstructive lung disease. Very clear, as simple as this. Okay. So just try to revise, it's very simple. Once you answer, you try to answer yourself, it actually makes a lot of sense. Okay. All right. Now, having understood this part of the flow chart, now let's go to the other side. What if you have done an FEV1 to FVC and you find that the value is actually less, okay, less than 0.7, okay, as per the gold, you find it is less than 0.7. In such a scenario, when the value is less, suppose you take the value to be around 0.4. Now, this is the scenario where you should consider obstructive lung disease as a top possibility, okay, a lower value of FEV1 to FVC ratio. In such a scenario, go for the vital capacity. Now, remember when I plotted the volume time plot for obstructive lung disease, you remember the vital capacity. I'll just show you that. I'll just show you the obstructive lung disease. Yes, here. You see the obstructive lung disease. Yeah, as you can see in your picture, the obstructive lung disease, the forced vital capacity, though the FEV1 is very much reduced, FVC was almost normal, correct? So, in such a scenario, when you come to this flow chart, okay, when you come to this flow chart, if the FVC is above is normal, okay, in such a scenario, you are going to consider obstructive lung disease. Okay, suppose it is not above the lower limit of normal. In such a scenario, you again go for the total lung capacity. Now, if the total lung capacity is reduced, in such a scenario, Remember, this is not going to be a pure obstructive lung disease. In that scenario, you are not going to get a reduced TLC. So that is a scenario where you are expecting a mixed defect, okay, where a restrictive plus an obstructive defect. And if suppose you have the TLC which is normal, you can again think of a obstructive lung disease. Okay, crystal clear. Okay, now if you have an obstructive lung disease in your hand, if you want to distinguish between a disease like, say, asthma and chronic bronchitis, or whether it is emphysema, you go for the DLCO. And remember, since the surface area is reduced in case of emphysema, which we have already seen, the DLCO will be low. DLCO will be low in case of emphysema, whereas in case of asthma and chronic bronchitis, the DLCO will be normal. Okay. So this is how you are going to deal if the FPV1 to FVC ratio is low. So are we very clear with this flow chart on the basic pattern recognition in your obstructive and restrictive lung disease as well as your pulmonary vascular disorders? So when you have your spirometric values given as well as your DLCO values given, remember, go in a systematic order and make conclusions. Most often, the clinical history will have enough and more clues to make a logical conclusion, but use the values as well to come to your final diagnosis. So this is such a simple topic on the distinction between the restrictive, obstructive, and the pulmonary vascular disorders. So I hope this is very clear to you. Say yes or no. Is this clear to you? Very, very simple. Okay. And I want every one of you to just teach one of your colleague also this one, so that you are also very thorough with this. Okay. Once you teach a couple of friends, I'm sure that this will stay there. You just go to the exam hall and write the answer. Okay. Only when you try to mug it up, creates problems for you. Okay. Often the exam question will be a simple, straightforward question. Okay. Don't worry regarding that. All right. So we have learned regarding the distinguishing features of a obstructive and restrictive lung disease from these values. Now let's go to the flow volume loops. Okay, in spirometry, you have the various flow volume loops. So let's try to study the flow volume loops. Simple, another 10 minutes, we are just going to learn the simple flow volume loops. First of all, let's see a normal flow volume loop. I want everyone to be very attentive. So let's see what is normal. So this is the flow volume loop. On the x-axis, you can see the volume. Y-axis, you have the flow, correct? And remember, in a flow volume loop, the part of inspiration is represented in the downward part and expiration is actually in the upward part. Okay, so you see here, the person is here, you see he is inspiring, and this is how it goes. That is from the residual volume to the total lung capacity is actually inspiring. Okay, and then you see here the patient is actually forcefully expiring. Okay, so this is the expiratory limb. There is an ascending part as well as a descending part. So you must understand that, okay, from this total lung capacity, okay, and the patient is expiring to the residual volume here. Okay, from the total lung capacity, he is expiring to the residual volume. And this one, as you can see, there is the expiratory part as an ascending limb, and that peak is referred to as the peak expiratory flow rate. Okay, this particular thing is the peak expiratory flow rate. Okay, so what are you seeing here? You are inspiring and then the forceful expiration. So remember, you have got to keep in mind this normal flow volume loop. And what is this gap between your total lung capacity and residual volume where he is forcefully expiring? That is going to be your forced vital capacity. Forced vital capacity. Very clear? Okay. So inspiratory limb, expiratory limb, forced vital capacity, peak expiratory flow rate, everything is very clear to you. Now, this flow volume loop also can have various abnormalities. Okay, that is what we are going to learn. Okay, so now let's try to make a distinction between the flow volume loops in case of a obstructive lung disease and a restrictive lung disease compared to a normal flow volume loop. Be very attentive here. The picture in the middle is a representation of the normal flow volume loop. This is the inspiratory part. This is the expiratory part. Okay, this is the normal flow volume loop. Now, when it comes to obstructive lung disease, as you can see here, this is figure 1, figure 2, figure 3. So figure 1 showing an obstructive lung disease. You tell me, what is the part of the flow volume loop that is most likely to be affected? Is it the inspiratory part or the expiratory part? The expiratory part, correct? Yes, because obstructive lung disease is predominantly a expiratory airflow limitation. Expiratory airflow limitation. Okay, so there will be a problem with the expiratory part of the flow volume loop, and in the expiratory part itself, if you carefully observe, the descending limb of the the flow volume loop almost has a concave shape. Okay, almost has a concavity. Okay, so that is the abnormality that you would notice in the flow volume loop of a obstructive lung disease. Okay, obstructive lung disease, that is very clear. Okay, now when it comes to restrictive lung disease, okay, now you are going to see the picture number 3, that is a restrictive lung disease. Now here the predominant problem, it is a inspiratory problem. So you see the inspiratory limb of the loop, it is again a very small one. Okay, but expiration is taking place, but again, since the amount of air that has come in is less, the amount of air that going out also will be less. So you can see this is a very much small loop that you are seeing. And if you remember, even when we saw the volume time plot, the plot was very similar to normal individuals, but it was that it was smaller. Here also you will have a flow volume loop, the shape of which is again similar to the normal one, but very small. But this is again contrast to obstructive, where you can have a change in the shape. You have a concavity in the downward part of the expiratory limb. Okay, so that part you have got to keep in mind. Okay, now most likely in the exam, they might give you a obstructive or a restrictive lung disease, and when you have a normal appearing loop, very small, that is likely to be restrictive, and obstructive always look for the concavity in the loop. Now another important point is that when you have a obstructive lung disease, always make a point, even in your spirometry lab as well, you give a bronchodilator inhalation to the patient, because in case of a bronchial asthma, you have a bronchodilator reversibility, okay, which we have already discussed in bronchial asthma module. So bronchodilator reversibility is there. So which means, when you give a bronchodilator, there is going to be an improvement of the pulmonary function test, your FVC, in case of your bronchial asthma. You see here, this one is the brown color is for the loop before the bronchodilator use, and green is for after bronchodilator use. You see the change in the shape of the curve after bronchodilator use. You see that there is a significant improvement here. Okay, this brown was the initial one, number 1, and you see that it has gone to number 2. So you say that when there is a bronchodilator reversibility, when do you say that? You say that when the FEV1 increases by more than 12%, or there is a 200 ml increase of your FEV1, that is when you say there is a bronchodilator reversibility. Okay, here also you can see this is 1, this is 2. So if you have a bronchodilator reversibility, does it favor a bronchial asthma or COPD? It favors bronchial asthma. So remember, in your spirometry lab, always if your clinical suspicion is obstructive lung disease, once the graph is plotted, always go for the bronchodilator also. And again, after a bronchodilator, 15 minutes after a bronchodilator, you again do the test, and if you find that there is an improvement by more than 12% or 200 ml increase, it is a suggestive of a bronchodilator reversibility, okay, which is indicative of a bronchial asthma. Okay, so that is very important. So that again is an important clinical point also, which has got to be kept in mind. All right. Now next again is the flow volume loops in a couple of other conditions, that is in your airway obstructions. That is, the number A is actually the normal flow volume loop. Okay. Now what about B, C and D? Now in B I am talking of a variable obstruction. Okay. A variable extrathoracic obstruction. Okay. Extrathoracic obstruction. Now variable obstruction means it varies with the phase of respiration. So variable extrathoracic obstruction means the cause is outside the thorax, and when you have a variable extrathoracic obstruction, example is maybe a vocal cord palsy. Okay. So in such a scenario, in a variable extrathoracic obstruction, the problem in the flow volume loop is the inspiratory limb of the flow volume loop. The inspiratory part of the flow volume loop appears very small. The expiratory is appearing normal. You see, you compare with the normal flow volume loop. What is the part that is affected? The inspiratory part is becoming small. Whereas when it comes to the variable obstruction, but a variable intrathoracic obstruction, as in case of say suppose you are dealing with a tracheomalacia, okay, an intrathoracic trachea, okay, there is a tracheomalacia, okay, in the intrathoracic part. In such a scenario, you have a variable intrathoracic obstruction, and that is predominantly affecting the expiratory limb. Okay, that is predominantly affecting the expiratory limb. Very, very important. So that will be the shape. The final one is actually a fixed airway obstruction. A fixed airway obstruction, that is, there is no change with the phases of the respiration. The classical example is that of tracheal stenosis. Okay, is that of a tracheal stenosis, where both the expiratory as well as the inspiratory limb of the flow volume loop is very small. Okay, so that is what happens in a tracheal stenosis. So you should have a basic idea regarding the abnormalities here. Just to show a picture of the dynamic effect of an intrathoracic airway obstruction. So if it is intrathoracic, remember the predominant problem will be, the obstruction will be more in the expiratory part, that is going to be affected. But when you think of a extrathoracic airway obstruction, okay, in such a scenario, what will happen is that it is the inspiratory part of the flow volume loop that is going to be affected. Okay, so I hope the flow volume loop concept is also very clear to you. Just to summarize everything, what have we learned? We have learned the basics of spirometry. We have seen the DLCO also, and we have seen how with the various spirometry values as well as DLCO, we are able to compare and contrast the obstructive, restrictive and the pulmonary vascular disorders, as well as the flow volume loops. What is the pattern that you get in case of a obstructive lung disease, where you have a concave part of the descending limb, which may reverse with bronchodilator as in case of a bronchial asthma, which may not reverse in case of a COPD. And when it comes to restrictive lung disease, remember you have a very small flow volume loop. Okay, very important because the capacity is very less. So that is again a miniature form, a small form. You have got to keep that in mind. So again, and also the variable obstructions, okay, the flow volume loop changes as in case of variable extrathoracic obstruction, variable intrathoracic obstruction, you have got to keep in mind, and also the fixed obstruction. Now, any one of these can come as a case scenario. You have got to be very thorough with this. Remember, it is nothing complicated, very simple. All what you need is that some basic understanding of the normal spirometry values and what are the abnormal patterns that occur. I hope this module is clear and was useful for all of you. Okay.